Welcome everyone to the day 3 of the webinar series. We will kick off our program at 6:35. In the meantime, I just want to let you know that if you have any questions, just post them in your chat. And if you want to ask any question directly with our panelists, just raise your hand and we'll allow you to speak.
Good evening, everyone, and welcome to this health education and promotion webinar series. Like Suji mentioned at the start, this actually is our third webinar, and this is this celebration of the National Asian and Pacific Islander Month in the entire month of May. This webinar series is sponsored and presented by the Ohio Asian American Health Coalition and is funded by the Ohio Commission on Minority Health. My name is Cora Munoz, and I'm the president of the Ohio Asian American Health Coalition. And we're proud to present to you this webinar this evening with such good presenters, experts in their field, and also exciting topics. I'm so glad that you were able to join us. Just a little bit about the Ohio Asian American Health Coalition as an introduction. This is an organization that was founded in 2005. And actually it's an alliance of several communities, agencies, and individuals focused on the health and well-being of Ohio Asian American and Pacific Islander population in the entire state of Ohio. Okay. I do want at this point, I want to mention the organization members. Okay. And just quickly, in Columbus, we have the Asian American Community Service Council, the Asian American Community Services, the Asian Festival Corporation, the Lao Volunteer Donation Organization, and the Bhutanese Community of Central Ohio. In Dayton, our member organization is the Asian American Council in Dayton. In Cincinnati, the Asian Community Alliance. In Akron, Cleveland area is Asian Services in Action. And in Toledo, the Chinese Association of Greater Toledo. If there are members of our member organizations in this meeting, please indicate in the chat, and we welcome you, and we appreciate your membership. Okay. I also want to mention that Greg Lamb, who's one of our presenters, is the Vice President of the Ohio Asian American Health Coalition, and Manju Sankarappa is the Executive Director. Okay. So just a little bit about the National Asian and Pacific Islander Month. I will talk more about that later, but just to mention that this started as just a week-long celebration in 1979 with President Jimmy Carter, and then it expanded to the whole month in 1990 through President George W. Bush. And the month of May is really a special time because on May 7, 1843, the first Japanese immigrants arrived in the United States, and in May of 1869 marked the completion of the Transcontinental Railroad, which would not have been possible without the contribution of Chinese Americans. So I'd like now to introduce Manju Sankarappa to start our program. Welcome, everyone, and I hope you'll find this session very informative and enjoyable. Manju.
I am Executive Director of the, Can you hear me? Okay, all right.
Yes.
First, I didn't realize. Okay, my name is Manju Sankarappa. I'm Executive Director of the Ohio Asian American Health Coalition. And
I want to tell you something. I really want to tell
you. Can't. You have to wait. You have to do. Okay. Okay. I'll talk to you later. All right. Okay, sorry. That's my grandbaby, so I have to kind of take care of that. I'm going to, first of all, I do want to say, as Asian Pacific Islanders Heritage Month, we have started with a 5 webinars, which started last Friday and Saturday, and this is our third one in the series. And as you know, today we are focusing more on chronic diseases, that are highly prevalent in the Asian community. So we have three guests today. Dr. Greg Lamb will be the first one. Uh, Dr. Lamb serves on Ohio Asian American Health Coalition as a vice president. He's best known for his care and deep commitment to his patients, for which he has been recognized with several patient care awards since joining Ohio Health in 2009. Dr. Lamb currently serves as the Medical Director of Cardiovascular Services at Berger Hospital in Circleville, Ohio, where his clinical interests include heart disease prevention, congestive heart failure, vascular medicine, valvular heart disease, and women's health. Now, Dr. Lamb has all his accolades for him. However, he is also very passionate about the community service. I really want to stress on that because with all his busy at the work, he still gives us enough time, and he has also, anytime we want something, I can call Greg and he's always there as my advisor. So I really want to thank him. Greg, I want to welcome you to the Ohio Asian American Health Coalition's second. Actually, you attended last year, 2 years ago. So this is your second in-person kind of event. So I want you to talk about education on diabetes and cardiovascular diseases. Thank you, Greg.
That sounds good. Well, thank you so much, Manju. I am going to see if I can share my screen now. And you guys let me know if this is coming up okay. Let's see here. Let's see. What do you guys see there now? Do you see my slides?
Yes.
Yeah, and okay, perfect. Well, thank you so much, Manju, and thanks so much, Cora. It is an honor for me to be here with you guys today. There's a lot to talk about. So we're going to cover diabetes and cardiovascular disease. So I'm just going to go ahead and get right into it. But just a little bit of background. So even though I'm a cardiologist by training, I do a lot of work in diabetes, and I've been working with Manju and Cora for the Screen at 23 initiative, which is just to raise education and awareness about diabetes. We'll talk about that a little bit more in the talk, but I just want to warn everyone, there's a lot to cover, and I only have 25 minutes, so we're gonna go pretty quickly. If anyone has any questions, please feel free to raise your hand and ask, and then we'll try to hit that at the very end. And so our objectives today, there's a lot. So we're going to talk a little bit about the background on diabetes, what is diabetes, and some disparities. And then we're going to transition to coronary artery disease. So what is coronary artery disease? Just the basics of these, and then talk about a little bit about cardiovascular disparities for AAPI, the Asian American Pacific Islanders. And then lastly, if we have some time, the conclusions and the Q&A. And so let's start with diabetes. Diabetes is something that's really prevalent, and I'm sure that many people have heard about it. Some people may have it or may have family members that have it. About 30 million people in the United States has diabetes. The interesting thing, though, is that there's still a lot more people out there that have diabetes, but they don't know about 1 in 4. This is really, really expensive for us as a nation, about 237 billion in annual cost a year. That's 237 billion. And the adjusted mortality of life is about 266 plus million. The interesting thing is that these are expected just to keep increasing. And so I was just reviewing some data right before I came here, and by 2045, it's estimated that there'll be close to 760 million people worldwide with diabetes. So this is a huge problem in the world and in the United States. But what about here in Ohio? So here in Ohio, this is actually a really big problem as well. So in Ohio, the diabetes burden outpaces that of the United States. So here in Ohio, it's about 11.7% have been diagnosed with diabetes, whereas in the United States, it's 9.4%. Central Ohioans is actually slightly worse, about 10.6%, and 35.3 have prediabetes. Prediabetes is a precursor to diabetes. So your blood sugars are a little elevated, but not quite at the diabetic level. And we'll get to that in just a little bit as well too. So here in Central Ohio, our statistics are worsening. So in Franklin County, where I am, Franklin County has some really, really high rates. So it's about 20, or I'm sorry, 30 per 100,000 per population, whereas in the United States, it's closer to like 24 per 100,000. The diabetes mortality in Columbus is about 55% higher than in the United States alone. Um, and, uh, and one of the reasons why is a lot of lifestyle factors. And we'll talk about that in just a little bit. And one of our other speakers later on will also speak to lifestyle and diabetes and also diet as well too. And so just a little bit more is kind of what we're talking about how many people have diabetes in the United States and how this is only expected to increase as the years go on. So what is diabetes? Now that we know how much it affects the United States and how much it affects us here in Ohio, what exactly is diabetes? So what diabetes is a lot of times when you eat food, the food gets broken down into sugars, and the sugars get ingested and it gets sent to the bloodstream. Insulin is a hormone that's made by the pancreas, and it helps to get the sugar from the bloodstream into the cell where it can be used as energy. But with diabetes, you have too much sugar in your blood. And now, when that happens, that could be really, really bad. And so, when you have too much blood sugar, because you don't have any insulin that's produced, that's what's called type 1 diabetes. On the other hand, if you have insulin, but the insulin just isn't working very well, and so, for instance, your tissues aren't responsive to the insulin, that's called type 2 diabetes. And one question that people has is, well, what exactly is insulin? You can think of insulin as sort of the mechanism that can get sugar or glucose from the bloodstream into your cell. It's a hormone that's released, and it actually gets released all over your body. And it's this insulin that's actually critical to the diabetic state. When you have abnormal insulin function, whether it's too little bit of insulin or the cells don't respond to the insulin, then what you do is you actually get higher levels of glucose or blood sugar that accumulates in your system. And with time, that sugar, sometimes it can get filtered through the urine, but over time it can start to have a toxic effect on your peripheral tissues to cause a whole host of problems. Um, and and when we talked about the types of diabetes, there's in general 3 separate types. So type 1 diabetes, and in type 1 diabetes, you don't make any insulin at all. And these people are usually more dependent on insulin that has to be administered exogenously. The second type is type 2 diabetes. And in type 2 diabetes, this is actually the more common type of diabetes. It happens later on in life. You make insulin, but the insulin that you make doesn't work very well. You have insulin resistance where the peripheral tissues just aren't responsive to the insulin. And so the insulin doesn't allow the blood sugars to get from the bloodstream into your cells. And therefore you have higher levels of blood sugar in your system. And then the last is gestational diabetes. And that's a condition that you can get during pregnancy itself. So let's go a little bit more into each of these different types, because this is a question that comes up pretty often. Sometimes people get kind of confused with type 1 and type 2 diabetes. Type 1 diabetes, we typically see this for people before the age of 30. Although it's really interesting because this is sort of evolving, and now about 5 to 10% of the patients diagnosed with diabetes over 30 actually have type 1 diabetes, not type 2 diabetes. In this case, the causative mechanism is an autoimmune disorder. And so what that means is that your body actually attacks the pancreas that produces the insulin. And so therefore it doesn't have any insulin production itself. It can also sometimes develop as a consequence of trauma or damage to the pancreas itself. These people usually are not overweight or obese. They're usually very, very thin. And in this case, as we mentioned, they actually do require insulin in order to actually have the effect of getting the blood sugars from the blood into your system. And this is a lifelong disease. On the other hand, type 2 diabetes is a condition that typically develops for patients over the age of 45. Although, one of the caveats is that we're seeing more and more obesity and the sedentary lifestyle with some of our patients. We actually are seeing type 2 diabetes at an earlier age, but historically, it typically happened for patients over the age of 45. There are certain ethnicities that are predisposed to type 2 diabetes. Asian Americans and Pacific Islanders are one of them, in addition to our African American and our Latino colleagues, as well as American Indians. And there's usually a genetic component. So as opposed to the type 1, where there's either some trauma or there's an autoimmune disorder, there is a genetic component. So you typically will have like a brother, a sister, a parent, a first degree relatives that also has a history of diabetes. These people are overweight. So their BMI, their body mass index, is typically over 25, although we'll talk about that a little bit more in just a little bit. They're physically inactive, or they have a sedentary lifestyle. And as a consequence, in addition to being sedentary and overweight, they also have high blood pressures. They can have some lipid derangements as well too. So their good cholesterol, their HDL cholesterol is usually low, and typically we want that high because that's a good cholesterol. Conversely, their bad cholesterol is usually high, and typically we want that low. And then another form of bad cholesterol, their triglycerides, is also elevated as well too. And this last point, sometimes people with a pretty rare condition called polycystic ovarian syndrome, or PCOS, can also have diabetes as a result of the metabolic abnormalities with PCOS too. Now, gestational diabetes is something that happens for women and happens with pregnancy. In fact, about 7% of pregnancies in the United States could develop gestational diabetes. In this case, they don't have diabetes initially, but this develops during the pregnancy. They typically recover, but what we now know is that if you've had gestational diabetes and recover, you're not out of the woods yet, because anywhere from 35 to 6% can develop diabetes later on in life. And so for us, one of the risk factors for developing diabetes later on in life is if you had gestational diabetes when you're pregnant. So that kind of covers the different types of diabetes. One of the things I want to go over is symptoms. So for the audience, what kind of symptoms do you look out for that might make you suspect or worry about that you might have diabetes? The tough thing about diabetes is a lot of the symptoms are nonspecific. So you could have excessive thirst, excessive urination, but the problem is that you might not notice it because it doesn't hit you all at once. It's kind of a gradual thing. But over time, you find, gosh, I'm drinking all the time, or I'm urinating all the time. You could have excessive hunger, despite eating copious amounts of food. And in addition to that, you might find that you're just fatigued all the time. Now, diabetes, as we mentioned, can affect a variety of different organs. And so it can affect your eyes, it can affect your heart, it can affect your kidneys, it can affect your periphery. So sometimes you actually might notice some blurry vision. Other times it actually might manifest as chest pain or shortness of breath because of its effects on the heart. Sometimes it can affect your periphery and you might have some abnormalities in sensation or with nerves. So you might notice some tingling in your hands or your feet or the loss of sensation there. For men, they could have erectile dysfunction. And for women, because of the elevated sugars in your urine, they could have frequent vaginal infections with yeast infections. And so if you might have some of those symptoms, the next question you might have is, well, who should be screened? This slide is a little busy and I apologize for that. But the one thing that I did want to point out is that before we used to screen patients with a BMI, a body mass index above 25. We now know though that for Asian Americans, it's a little different. And the reason why is because Asians just aren't as heavy as our Caucasian colleagues. And the BMI initially was developed over 200 years ago, and it's meant mostly for Caucasian males, but Asians aren't the same. And so what we now know is that perhaps we should be screening at a lower BMI for our AAPI populations, and the BMI should be 23. There is a national initiative called Screen at 23, meant for Asian American Pacific Islanders to be screened for diabetes at a BMI of 23 instead of 25. With the help of Manju and Cora, we've tried to initiate this as a proclamation here in Ohio, and we're really close to getting that done through our state legislature. It's very exciting news because once we have that, then we can actually really increase our education amongst our patients and also with our primary care providers as well too. And once you are screened for diabetes, then there's certain criteria between the diabetic range, the pre-diabetic range, and the normal range. We won't necessarily go into all of the criteria because that might be a little much, but just know that there's, after the normal range, there's a pre-diabetic range, which means that you're the next step before hitting diabetes. And then the next step after that is diabetes. There's certain tests that we can do to test for diabetes. Um, we won't go through all of that, but the one thing I do want to mention is that we now know that for Asian Americans, the best test to test for diabetes is the oral glucose tolerance test. In this test, what we do is you go to the doctors fasting, they'll administer a glucose load, wait 2 hours, and then check your blood. And then depending on what your blood sugar levels are, that's how we know if you're normal, if you're in the pre-diabetic range, or if you're in the diabetic range itself. Treatment for diabetes is a lot. There's a whole bunch of different medicines, complex medicines, highly evolving medicines. We won't necessarily go into all of that, but medicines, including insulin shots and oral medicines, are the mainstay. One of the things that we'll talk about a little later on is lifestyle modifications. So, diet and exercise, that's hugely important for the treatment of diabetes. In fact, some of my patients can control their diabetes just with diet and exercise without actually having to take medications or having to give insulin shots. And then lastly, as an adjunct to the actual treatment for diabetes, we actually recommend treatment for blood pressure and reducing cholesterol as well too. Um, I'm just going to just skip ahead just a little bit because I know we're running short on time, but there are some things with diabetes that puts Asian American Pacific Islanders at a little bit higher risk. One of the things that we know is that Asian American Pacific Islanders have different insulin sensitivity compared to our non-Asian cohorts. And so that may be one genetic reason why Asians might be at slightly higher risk for diabetes. The other thing has to do with risk factors. And we know that for certain of our Asian American subgroups, a sedentary lifestyle plays a role. So for instance, with Asian Indians, this has been pretty well documented and pretty well studied. And this might help explain why there's a little bit of a disparity for Asian Indians in their higher rates of diabetes. This is actually a really interesting study. And what this study showed us was that even if we had our different ethnic groups and we had them exercise the same amount, the effect of exercise for our Asian populations is less compared to other groups itself, compared to other groups. So we know that maybe for our Asian populations, we have to actually be a little more cognizant of it. We actually have to stress diet and exercise a little bit more, and we have to screen for them a little more rigorously compared to our Caucasian populations or other populations itself. Now, one of these things this brings up is the differences in risk factors in diabetes. This actually relates hand in hand to heart disease. And so in the last 10 minutes that I have, I just want to switch over to heart disease, which in and of itself is a huge, huge area. We could spend days talking about cardiology disease, but I'll try to summarize just some of the big parts in the next 10 minutes or so. So cardiovascular disease in the United States is a huge problem. It's the number one cause of death in the United States. About 735,000 Americans each year have heart attacks. And of that, about 610,000 per year die. But we know that cardiovascular disease affects ethnicities differently. And we'll get to that in just a little bit. So the question is, well, what are we talking about when we talk about cardiovascular disease? And in general, typically we talk about cardiovascular disease or coronary artery disease. Coronary artery disease is when there's blockage in the blood that provides, in the arteries that provides blood to your heart. And so because there's blockages in the arteries, you're not getting enough blood flow to supply oxygen to your heart. And the heart is simply a muscle. And as a result, when you're not getting enough blood and oxygen, that can cause damage to the heart muscle itself. What are some of the causes of cardiovascular disease? What predisposes you to cardiovascular disease? Well, we know age does. So age over the age of 50 or 55. Again, if you have a family history, we know that there's a genetic component to this. Before I've been in Ohio for the past 12 years. Before that, I was at Duke University, and we had this whole huge genetic study. We called it CathGen, where we actually took blood from all of our patients coming in, and we did genetic analyses. And it turns out that it's actually much more complicated. There's a whole panoply of genes that play a role in cardiovascular disease. We haven't quite figured it out yet, but we know there is a genetic component. Males are at higher risk of having cardiovascular disease compared to females, premenopausal females. And the thought is that the estrogen from premenopausal females has a cardioprotective effect or a vascular protective effect. Interestingly, for females, once they're postmenopausal, their incidence of cardiovascular disease is the same as men. And so we think that there's some protective effect of estrogen. Of course, if you have a diet that's high in cholesterol, cholesterol is actually what forms a plaque in the arteries. And so higher cholesterol can contribute to cardiovascular disease. Similarly, if you have high blood pressure, if you smoke, smoking accelerates the formation of plaque in the arteries that feed your heart. So even if you smoked 20 years ago and you quit 20 years ago, unfortunately, that's still a risk factor for the development of cardiovascular disease. And then also a sedentary lifestyle, a fatty diet, psychosocial factors like a highly stressful job or type A personalities, that could also predispose you to cardiovascular disease. The signs and symptoms. So unlike diabetes, which sometimes can be surreptitious, for heart attacks, sometimes it can be pretty pronounced. You get all of a sudden chest pain. A lot of times people will point right to the center of the chest and they'll say it's almost like an elephant sitting on their chest. They can get arm pain or jaw pain. They can get short of breath. They start sweating profusely. They could get nauseous or vomiting. They could be dizzy and lightheaded. Sometimes for a lot of males, they just feel really anxious, or they can just feel really tired and weak. And those are the signs of a heart attack. The signs of cardiovascular disease or blockages that happens over time, that can be a little more subtle. And sometimes people they just say like they just feel really tired. My dad is a good example of this. So my dad was very active. He just was slowing down over time, and he didn't really realize that he was because it happened over years. Turns out when he saw his doctor, they were concerned and they eventually did a heart cath, and he had a 99% blockage in the main artery that runs down the front of his heart. But because it happened gradually over time, and because fortunately he was active, he just noticed a very slow, gradual decline in his physical functioning. And he didn't necessarily have a heart attack. Now, treatments for this has evolved dramatically over the years. So before, we used to say nothing to do, just bed rest. We actually used to let their blood pressures be really, really elevated. That's completely changed. Now we're actually very aggressive in opening up those arteries. We can open them up with balloons and stents to open up the plaque and to kind of smush it against the side of the walls. We can do bypass surgeries to bypass the blocked arteries. But most importantly, we have a host of different medicines, these really highly evolved medicines to help keep the arteries open, to help lower your blood pressure, to help lower the cholesterol levels in order to help prevent the recurrence of cardiovascular disease. But again, most importantly, diet, exercise, weight loss, and lifestyle modifications is really important to prevent cardiovascular disease and also to prevent the recurrence of cardiovascular disease. Now, one thing in just the last few minutes that I have is I want to talk about some of the disparities we see in cardiovascular disease for Asian Americans. So about 5% of Asian Americans have cardiovascular disease, but this accounts for 22% of all deaths. The reason why this is important is because as the Asian American population continues to expand, this will become a significant public health problem. Interestingly, in the United States, cardiovascular disease is the number one cause of death in the United States, but for Asian Americans, it's actually not the number one cause, it's the number two cause, secondary to cancer itself. The prevalence of heart disease is actually lower in Asian Americans compared to whites, but proportionally more Asian Americans die from cardiovascular disease. So the question is why? And the other question is, are those statistics really true? We know that our populations are really diverse, right? So, for East Asian Americans, there's Chinese, Japanese, Korean, Filipino, Vietnamese, Laotian, Cambodians, Thai. We have the South Asian Americans with our Asian Indians, the Nepalese, the Bangladeshis, and then we also have our Pacific Islanders with the Hawaiian populations. So is it really true? Can we really lump all of those statistics together? Turns out, not really. Once we start to tease apart this a little bit more, we find that there are distinctions between the ethnic subgroups. And this is something that I know that Dr. Munoz and Manju and I have been really advocating in the importance of disaggregation of our data. So we have a better understanding of the ethnic subgroups. And we know that by lumping all the Asian Americans together, it really hides some of the differences between the groups. So for instance, even though we said that Asian Americans had a lower prevalence of heart disease compared to whites, it actually isn't true. So Asian Indian men and women actually have higher mortality, Filipino men have higher mortality, and Japanese men have higher mortality. Part of the reason why is the risk factors. And so when we take a look at obesity, diabetes, heart disease, we see that it varies tremendously between the different groups and the incidence of it, which is kind of interesting because, so for instance, we see that being overweight is highly variable. It affects Asian Indians more so than the Vietnamese. But when you take a look at other risk factors like diabetes, we find that it is drastically different. So for Asian Indians, it's higher, but the heart disease is lower. Whereas with other people, like with Koreans, the heart disease is higher, but the incidence of diabetes is lower. This gets really confusing, but the bottom line is it points out to us that we really need more data to better understand the effects of risk factors on cardiovascular disease and diabetes so that we can best serve our population. Another example of this is tobacco use. So about 9.6% of Asian Americans are smokers in general. But when you break it down, turns out Korean Americans are the highest smokers. They smoke twice as much as the Japanese, who also smoke about twice as much as the Chinese or Asian Indians. So even though we can say that tobacco may be a risk factor, we now know that we may be more specifically able to target our interventions to better serve our individual populations. I won't go over the rest of these just for time because it just sort of hits on the same theme. There's data for this for hypertension, for dyslipidemia, for diabetes, but this just tells us that we need to do a better job in looking at risk factors. But the other thing I want to point out just briefly, these are just my last two slides, is that the treatment for Asian Americans are different. And this is more of a systemic and more of a social effect. So Asian Americans had the second longest times for treatment for myocardial infarctions. And they also had a 20 to 30% lower adjusted odds ratio of using emergency services when they had stroke symptoms. Why? Why is that? Is it more of a cultural bias? Is it because that when Asian Americans go to the emergency room, they're just not taken seriously? We don't know, but we do know that from a system standpoint, we need to do a better job. So I am slightly over my time. I apologize for running late. Just in conclusion, we briefly reviewed diabetes, coronary artery disease. We discussed some of the differences in risk factors, and also we discussed some of the health disparities for AAPIs that may lead to our worsened outcomes. I know this is really brief. I would love to discuss this in more details. If anyone has any questions at all, please feel free to reach out to me. But I want to thank you for your time, and I'll turn this back over to you, Manju. But thank you very much.
Thank you, Greg. That was a great talk. Now, we can have this a whole day of session when you have some time on a Saturday or Sunday, then we can get all these people back, okay? So that will be great. You did a super job. I'm sure there will be questions they'll be asking at the end of the session rather than the beginning, okay? So we're going to go ahead and go to Dr. Cohen, Chari Cohen. Okay, you need to change the speakers.
Great. Can you hear me?
Yeah, I can hear you.
Perfect. Thank you so
Okay.
much. It's really nice to be here today. And I'm very excited to be celebrating and commemorating Asian Pacific Heritage Month. I'm going to be talking a little bit about hepatitis B today. We're going to go over what hepatitis B is and talk a little bit about what's happening around the country, how people can prevent and hepatitis B and get tested for it, but also how people can get involved in addressing hepatitis B, what's going on around the country, and in case anyone wants to start advocating or educating or becoming involved in some of the amazing programs that are happening in Ohio and around the US, we will share that. So I'm going to go ahead.
Chari, I would like to introduce a little bit more about you.
Sure.
Chari, Chari Cohen is a vice president of Hep B United, and she has worked on Hep B United since 2011. And she is a proponent. She works with all the governmental officials as well as CDC. She has put this program together for since 2011. And that's how we started talking to each other, really. Only after about 2013 and 2014, we received a grant from CDC to do the hepatitis um, tracking. So this included vaccination, screening, as well as linkage to care. So we were really successful. And as you know, Asians, foreign-born Asians, and Africans are the most susceptible to hepatitis B. But Shari will talk about it. And also, there is a national hepatitis B viral foundation where they're trying to eliminate the hepatitis B by a certain date. And Cherry is going to give us more information on all those things. Go ahead, Cherry. Sorry.
No, I'm sorry.
It's okay.
I just jumped right in. All right,
Yeah.
I am now going to share my screen. Let's see. Okay, can you see that?
Yeah.
Perfect. I'm gonna move on into slideshow. So I'm gonna talk a little bit about hepatitis B today, and we'll start with sort of a Hep B 101. And as Manju mentioned, hepatitis B is associated with health disparities for Asian American, Native Hawaiians, Pacific Islanders, mostly because of the fact that the virus that causes hepatitis B infection it's an ancient virus, and it's been around on Earth for thousands of years. In fact, there's been research that has even found the virus in mummies that are over 3,000 years old. So we know the virus has been around for thousands of years. And because of how it's transmitted, it is very commonly transmitted through generations. Even though it is not a genetic disease, it sometimes can seem like a genetic disease because it impacts multiple members of one family. So we're going to talk a little bit about hepatitis B today. Hepatitis B is a virus, and it causes a liver infection. So it is a virus that specifically infects the liver. And even though we don't talk about it that much, it is one of the most common viruses in the world. In fact, almost 300 million people in the world have a chronic hepatitis B infection, meaning they have hepatitis B virus in their liver and in their blood, and their body is not able to fight off the infection. So they will have that virus in their blood for essentially as long as they live. It is a chronic infection in many, many cases. So around 300 people worldwide have chronic hepatitis B. And in the US, a lot of people have it too. Over 2 million, almost 2.5 million people in the US have chronic hepatitis B infection. So there's a couple of problems with having a hepatitis B infection. One is that it's silent. So people can live with the virus in their liver for decades even without knowing it, because most people don't have any symptoms. And so if you don't have symptoms, you don't know you have it, if you're not diagnosed, then you can't take action. It's just like any other chronic condition where if you seek medical attention and you have you make some lifestyle changes and you take antiviral medication as you take your medicine as needed, you can actually live with hepatitis B for a very, very, very long time without any issues. So there are ways to prevent serious liver disease, but because it's a silent disease, people can live with it for a long time and not take any action against it because they don't know they have it. The other issue is that most doctors don't test for it, right? So hepatitis B is one of those infections, especially in the US, where a lot of healthcare providers aren't necessarily thinking about testing their patients for hepatitis B, and it's not universally recommended. So we get a lot of people who reach out to us and say, how do I have hepatitis B and not know about it until I'm 45 years old? Why? I go for a checkup all the time. Why wasn't I tested? Well, it's not part of routine checkups. And so if you want to be tested for hepatitis B in the US, usually you have to ask for it. And that's something that a lot of people don't know. But it is an issue because if hepatitis B goes undiagnosed and unmanaged, it can lead to liver cancer. In fact, hepatitis B is the primary cause of liver cancer around the world. But the great news is that it can be prevented. We can prevent both hepatitis B infections and we can prevent liver cancer. And we're going to talk a little bit about that today. Hepatitis B, I'm going to talk a little bit about just quickly about transmission. Hepatitis B is transmitted from mother to child during childbirth process, and that's how hepatitis B is transmitted most commonly. Let me just swing over to my next. There we go. Because hepatitis B is transmitted through direct blood-to-blood contact, you do need direct blood-to-blood contact to get hepatitis B. So very often it is transmitted from an infected mother to her baby because of the blood exchange that happens during childbirth. So some babies are actually exposed to the virus at birth, and that's when they become infected. But it can also be transmitted through unsterile healthcare practices, unsterile needles. Often hepatitis B virus can be transmitted through households when people share things like razors or earrings or toothbrushes. So anything that can transmit blood from one person to another. And it's also sexually transmitted. So the really good news is that hepatitis B is not casually transmitted. So you cannot get hepatitis B from hugging, kissing, coughing, sneezing, sharing food with people who have hepatitis B, sharing family meals, sharing bowls, sharing drinks, eating food prepared by someone who has hepatitis B. None of that can transmit it. And that's the really good news. The other really good news is that hepatitis B, the virus, is completely preventable. And so there is a vaccine, and it is very safe and very effective. In fact, over 1 billion doses of the hepatitis B vaccine have been given out since 1992 around the world. So worldwide, almost all babies get the hepatitis B vaccine when they're born or shortly after. But depending on the country, some countries have been doing this since like the late 90s. Some countries have been vaccinating babies since the mid 2000s. And so depending on where you're born, if you weren't vaccinated at birth, then you could be at risk for hepatitis B infection. So in the United States, a lot of adults are unvaccinated because they were born before we started giving out the vaccine routinely. And so it's really important, especially for adults in the US, to ask to be tested for hepatitis B. And if you don't have hepatitis B infection, then to ask to be vaccinated. So hepatitis B does represent the largest health disparity for Asian Americans, Native Hawaiians, and Pacific Islanders in the US, and also for people from Africa, people of African origin, people from African descent. And so what we know is that in the US, among Caucasian Americans, less than 1% have hepatitis B infection, but among Asian American Pacific Islander communities, sometimes 10 to 12% can be infected with hepatitis B. And again, that is just because of how the virus has been propagating around the world for thousands of years. So this is, it is something that we like to think about as an important health disparity and something that Asian American Pacific Islander community should be thinking about. And one of the things that we do with our partners around the country is to go out into communities and help people learn more about hepatitis B, help people talk more about hepatitis B, and maybe even prompt some folks to ask their doctor to get tested. So if you are in a community where there is, and I'm going to, at the end, I will talk about where Hep B United partners are. In fact, Ohio Asian American Health Coalition is one of our biggest and strongest partners. And I know that throughout the year, they offer free hepatitis B testing. So I would recommend getting tested if you haven't been. I know it's been really difficult in the past year with COVID, and a lot of our sites have had to stop doing hepatitis B testing because of the coronavirus, but now things are opening up and we are starting to see more communities increasing their hepatitis B testing now. So that's the biggest message, is ask your doctor to get tested for hepatitis B, or go online and see if you can find a place to get tested. And if you test negative, then you can be vaccinated, which is really good news. So I talked about this already. One of the questions we get a lot with the vaccine is, will the vaccine help me if I already have hepatitis B? So the answer to that is no, unfortunately. The vaccine for hepatitis B is only preventive. So it can prevent someone from getting a hepatitis B infection if they haven't already been infected. But once someone is already infected, then the vaccine won't help them. And in the US, there are actually 2 different kinds of vaccine that you can get. One is given as 3 doses. I think we're all getting very familiar with multiple dose vaccines. But the 3-dose hepatitis B vaccine is given as 3 shots over a 6-month time period. And once you're vaccinated, you're protected for life. So you never have to worry about getting vaccinated again for hepatitis B. But there's actually another hepatitis B vaccine by a company called Dynavax, and it was approved 5 years ago. And it's only 2 doses. So you can actually be completely protected with 2 doses over 30 days. And again, once you get vaccinated, you should never have to be vaccinated again, which is really good news. So we get this question a lot. We talk with people around the country who have been newly diagnosed or who have been diagnosed with hepatitis B. And the question is, what do I do if I find out I have hepatitis B? And we tell people, well, first, hepatitis B is a chronic condition, just like any other chronic condition. And for the most part, it just means being routinely managed, something like having diabetes or having high blood pressure. If you're educated about it and you know about it, you can manage it. And the most important thing is finding a doctor to work with if you know you have hepatitis B. And finding a doctor who knows a lot about hepatitis B is important because they will know how to manage you and they will know how to treat you. And there are treatments for hepatitis B, and that's great news. When I started working in hepatitis B back in 1999, we didn't have any FDA approved treatments for hepatitis B, and now there are 7, which is, we've made such good progress. So what we know if you have chronic hepatitis B infection is find a good doctor, make sure that you get your liver checked out every 6 months or so. If you need medication, if your doctor prescribes medication, take it. And the medication for hepatitis B is a pill that you take once a day, and you take it every day. And the antivirals, the medication is really important because it can slow down liver damage. So it's not a cure. The current treatment that we have doesn't cure hepatitis B, but it slows down the virus so much in your body that it can prevent liver damage and it can prevent liver cancer. And that's really important. It controls the virus. The other thing that we talk to people about if they have hepatitis B is just making some healthy lifestyle choices. Things like alcohol and smoking can be really damaging to your liver. And if you already have hepatitis B, then alcohol can make it a lot worse. And so while we don't have a cure now, there are a lot of scientists working on finding a cure for hepatitis B. And what we are very, very hopeful about is that within the next 5 to 10 years, there will hopefully be some kind of possible a cure that we could get with limited treatment so that people won't have to take medication for many, many years. There are a lot of clinical trials that are opening up now and probably within the next year or 2. So we're really excited about the research progress that's happened. And if anyone is interested in learning more about maybe how they could learn about treatment, or they could learn about clinical trials, or are interested in talking more if they've been diagnosed with hepatitis B, you can learn more at our website at hepb.org. You can also call us. I have a phone number at the end. We do have a helpline. It's completely confidential. And if you have any questions about hepatitis B, we're there Monday through Friday through email or through phone, and we're happy to help as much as we can. So as I said, there is no cure yet, but we are very, very hopeful that there will be some kind of cure within the next 5 to 10 years. So what are we doing around the country? This is a really significant health disparity for Asian Americans, Native Hawaiians, and Pacific Islanders. So what are we doing? Well, one of the things that we're trying to do with our partners around the country is just raise our voice. This is where we need people around the country to speak up and raise their voice and talk about how important hepatitis B is in their community. And when we do that, we can make sure that we get more federal funding to get people tested and to get people into care. And frankly, we could get more federal funding for research for a cure so that we can get a cure. And so looking at this map, wherever you see a little black circle, that is where we have a partner, and we work together to, as Manju said, to eliminate hepatitis B in the United States by 2030. And this is something that is aligning with a global goal from the World Health Organization to eliminate viral hepatitis by 2030. In the US, The program is led by the Department of Health and Human Services, which is at the federal government. And we have partners at the Office of Minority Health, at the Centers for Disease Control and Prevention, at the National Institutes of Health. And then we have partners like us and Ohio Asian American Community Health Coalition, where we are working locally in communities to get people tested outside of the doctor's office even, and to get people into care, and to help people share their story so that we can start talking more about health equity and about Asian American health and health disparities, so that we can improve health outcomes for the future. One of the other things that we are working on is making sure that people with hepatitis B can't be discriminated against. And this is something that unfortunately we do see quite a lot of around the world. Very often people who have hepatitis B in some countries can't get jobs, or they can't go to school, or they can't immigrate to certain countries. And we are working with partners around the world to try and stop that. In the US, you are not allowed to be discriminated against if you have hepatitis B, but we still see it happen, unfortunately. The good news is that we have the law behind us. And so very often, we will see people who are being discriminated against in the US if they have hepatitis B and they want to be a doctor or a nurse or work in the healthcare professions. Luckily, the law is on our side. And so if someone feels like they're facing discrimination in the United States, they can call us at the Hepatitis B Foundation, and we will work with them and educate whoever is trying to potentially discriminate against them. And in every case, we are able to come to a satisfying conclusion, because people are protected in the US by the Americans with Disabilities Act. What else are we doing? So we do have a national viral hepatitis strategic plan that the Department of Health and Human Services has put out. And that plan gives us strategies for how we can eliminate hepatitis B in the US. And that's really important for us as community members and community leaders, because we can come together to help implement the strategies within that plan. The other very important thing for us this year is that ACIP, and I think we're all becoming familiar with these acronyms. So ACIP, which is the federal body that makes recommendations for vaccines, they are looking at the possibility of recommending universal adult hepatitis B vaccines in the United States this year. And that's really important for us, because right now, the recommendations for vaccines are risk-based and very hard to implement. And so only about 25% of people in the US, of adults in the US, are covered with vaccine for Hep B. So if this recommendation comes through, it will be really important for us. The CDC is also considering expanding their hepatitis B testing, meaning that by next year, it's possible that every person in the US can be recommended to get a hepatitis B test. And that is very important, because it helps take some of the stigma away, and it makes it easier to get people diagnosed. Many states around the country, including Ohio, are working on completing viral hepatitis elimination plans with coalition partners and with health departments. And of course, we've all been trying to find new ways to test and get people into care through coronavirus. So if you're interested in joining any of these activities, please feel free to reach out. You're welcome to join us. We do have at the Hepatitis B Foundation a storytelling program, and we work with people around the country who want to share their story about hepatitis B. You can go on our website and look at stories. You could sign up to be a storyteller yourself. And we also have an advocacy action center. So if you ever want to make your voice heard, we have opportunities throughout the year to talk with legislators at the state level, at the local level, and at the federal level, and just make our voices heard about the importance of Asian health disparities, and especially hepatitis B and liver cancer. So that's it for me. This is just a little bit about the Hepatitis B Foundation. Again, we're always around. You can find us at hepi.org. You can call us or email us, and we are always happy to help. I think that's all I have. So I will go ahead and stop sharing now. Great. Thank you.
We will have the question and answers later, so please stay on, okay? Thank you. Thank you so much for taking time to present this to us. It's really important. Okay, next topic is going to be um, Susmita Sadana. She is the author of Healthy Diabetic, and she is actually, I just realized, she has um, PhD in Russian studies, and she's doing her master's right now at Ohio State University. Currently, she's completing her master's in medical dietetics at the Ohio State University. She has done some surveys with in collaboration with her professors, considers herself as a lucky winner of South Asian genetic lottery. She inherited diabetes and hyperlipidemia from her family. This in turn led her toward better health with the right foods. You are what you eat is her mantra. She has spoken at community forums regarding healthy eating while being culturally conscious. And her book is really good because I have used it, and some of the recipes really work very well. Thank you, Susmita. Go ahead.
Thank you so much for that introduction. Um, as Manju said, I am the winner of the South Asian Genetic Lottery. So Dr. Lam presented the big picture of what diabetes is, and I am the face of that diabetes. So we will go into the micro level and look at what it is, how it is, what it means to be living with diabetes. So I wanted to talk a little bit about the overarching ideas that come into play when you're living with diabetes. We as Asian Americans are considered the model minority, as in, outwardly we may not look obese, but if you look at me, I was never obese, and I was diagnosed with type 2 diabetes in my late 20s, in fact. And I was here at Ohio State, and the doctors were confused. They kept asking me, "You're not obese. How come you're diabetic?" And I later realized that I am TOFI, thin on the outside, fat on the inside. So a lot of visceral fat came into play. My A1C when I was diagnosed was 11.8, which is a very high number. And my triglycerides, which is a bad lipid, was close to 1,000. This was almost 2 decades ago. So I'm dating myself here. But I tried medicine after medicine, and unfortunately for me, I turned out to be quite sensitive to the medication. So I was forced to look at lifestyle modifications, and I was pleasantly surprised at how well they have worked. And so 20 years since being diagnosed with those high numbers, I have, no retinopathy, no neuropathy, none of the side effects that come with diabetes. So the model minority is something to watch for. Dr. Lam mentioned about being screened earlier and at lower BMIs. That's important for us. So I want to talk about what role food can play in this journey, right? Once you're diagnosed with diabetes, that's it. You live with it for the rest of your life. So every meal becomes a choice: what to eat, what not to eat. But in this preoccupation, we forget to enjoy food. So I want to say that's really important. Food has to be fun. Food should be enjoyable. So I'll talk you through some easy ideas to be able to eat healthy food. Food is fuel for us. We have to realize that we have to eat well in order to function well. Food can also be medicine when required, right? So if we eat the right kind of foods, it can help us in our journey with a chronic illness like diabetes. And I would say look for food first. Don't look for supplements, dietary supplements, thinking that that would help us with, mitigate complications related to diabetes. And as Manju said in her introduction to me, you are what you eat. So if you choose carefully and joyfully, you will see major rewards. And I want to say, especially for people like me who are first generation immigrant citizens here, let's respect our Asian heritage. Let's not run away from it. Let's not look to, simply embrace our adopted culture, but be intercultural mediators between our Asian foods and American foods, so we can enjoy both, but in the right way. So I want to talk a little bit about the building blocks of a healthy diet. We need essential fatty acids, we need essential amino acids, we need carbohydrates, fiber, and antioxidants. So if you remember these few things, we will be able to put together a healthy meal at every meal without much of an effort. So why do we call some nutrients essential? I mean, how can fat be essential, right? It seems sort of counterintuitive. But we do need two types of fats, omega 3s and omega 6s, which our body does not make but requires for various functions. So, for example, why do we need these essential fatty acids? Essential basically means that our body cannot make it. So, we have to get it through foods, and these are building blocks for other complex molecules in the body that then drive biochemical reactions and other functions of the body. So for example, these essential fatty acids, you look at this funny picture on the side, this selfie. So the cell membranes in every cell in our body, is made of this phospholipid membrane, right? And this phospholipid membrane is made of lipids. So these essential fatty acids are required to maintain cell membrane integrity and that fluidity that keeps our cells healthy. Another thing is that we need vitamins, of which there are two kinds, fat soluble and water soluble. So we need healthy fats, we need good fats to absorb these fat soluble vitamins, right? Another thing that essential fatty acids will do is promote satiety. So if we eat the right amounts of fat and the right kinds of fat, we feel full because as Dr. Lam mentioned, one of the symptoms of diabetes is constant feeling of hunger. You may eat copious amounts of food and you could still be hungry. But if we include strategically these essential fatty acids, it promotes a satiety. You don't feel that hungry and you feel happier and satisfied. And then you can focus on things that really matter, like your work, your family, and things that you enjoy doing. And so we'll look at where you can find these essential fatty acids and how much of it adults need. But one thing to remember is that let's look for saturated fats and trans fats on food labels and try to avoid them. Right? Those are the ones that are implicated in cardiovascular disease and lipid malfunction. So, for example, omega 3s, which are have a major role in reversing inflammation in the body, and have a very significant anti-inflammatory roles, can be found in flaxseed oil, chia seeds, walnuts, walnut oil, and flax seeds themselves, and then in tofu. So these are easy to incorporate, and I have a couple ideas later on. So for adults, older than 19 years, we need about 1.6 grams for males and about 1.1 grams for females, and that's not hard to get. All you need is about a tablespoon or an ounce, ounce and a half or 2 ounces of walnuts, for example, in a day. So that is really not hard to do, but these are not things that we think about on a daily basis when we're planning our foods. One way to include it is to have chia seeds. You can see that an ounce of chia seeds has about 5.1 grams of alpha linoleic acid, an essential fatty acid. It's very easy. All you need to do is take a tablespoon of chia seeds and soak it in almond milk, or soak it in even water if you have no time, and then just drink it when you have a moment. And then omega 6s are found in pine nuts, in sunflower oil, in roasted pecans, and in sunflower seeds. And adults need about 17 grams for males and about 12 grams for females. Again, not very hard to get, right? If you take an ounce of sunflower seeds, that's about 9.7 grams of this omega 6. So these are things that you should, I would say, pay attention to essential fatty acids, because in my experience, this is the one thing that we never think about, to incorporate good fats, healthy fats. And then the second essential nutrient, again, once again, I want to remind us that the essential part means that our body does not produce it, but needs it in order to function optimally, right? So the role of these essential amino acids are too many to enumerate here. but they're important for tissue building and repair. They're important to synthesize hormones and neurotransmitters. And in meals, again, when you eat food, if you include good essential fatty acids and you include good, I mean, if you include these amino acids, good quality protein, it helps reduce that glycemic impact of foods, because carbohydrates, as we will talk about soon, play an important role in the life of a diabetic, right? They are closely linked to your blood sugars. So if you include essential fatty acids, if you include good quality protein, which is where you find amino acids, you will find that your blood sugars will cooperate much better with you than if you do not. So where can you find these amino acids? You can find them in protein, right? And what are some sources of protein? Meat. Again, you want to avoid fatty meat, right, with a lot of saturated fat and cholesterol, but you can good find lean meats, all kinds of seafood, except maybe shrimp, which can be high in fats. But you can have salmon, tuna, all kinds of seafood. Then eggs and tofu, these are some easy to find sources of essential amino acids. And then how much of protein does a person need, right? So this is a very generic recommendation. Of course, it varies from person to person. So for example, if you have hepatitis, that's a completely different you know uh, medical nutrition therapy for people suffering from hepatitis. Their protein needs are different. And then again, if a person who's diabetic is also on dialysis, we then carefully regulate their protein needs. But this is a general recommendation for most people, that you want to get about zero point 0.8 grams of protein per kg of your body weight. And there are 9 essential amino acids that can come only from food. So this is an important component not to be missed. So now let's come to this non-essential nutrient, right? There is no notion of an essential carbohydrate, right? And there is so much talk about carbohydrates in the media everywhere, right? Carbs are the enemy. Don't eat carbs, and go on a keto diet. But it's hard to have such to eliminate a whole um, food group. And plus, if you are a type 1 diabetic, or if you're a type 2 diabetic taking insulin, you do need carbohydrates, right? Otherwise you can become hypoglycemic. So there are a lot of considerations for diabetics. So let us figure out how to choose sort of healthy carbohydrates that can give us joy and yet not raise our blood sugars. So we know that typical Asian meals, no matter which part of Asia you come from, includes what? Definitely includes rice or some kind of noodles, right? Or in the case of Asian Indians, it involves rotis, involves naan. So all of that is a lot of processed carbohydrate that can shoot up your blood sugars no matter what medication you're taking. And if you're on insulin, you will see that you have to keep increasing your insulin level, insulin intake, in order to match the amount of these refined carbohydrates you're taking. So does this mean all hope is lost? No, not really, because a lot of us grew up eating rice, and there's a lot of emotions attached to it. So it's easy for medical professionals, healthcare professionals, to say, hey, stop eating rice, stop eating processed carbohydrates, and all will be well. But in reality, when you are by yourself and you're facing meal choices, you are drawn to what you grew up with, or you're drawn to these things. So here are some things you can consider, right? You can have red rice, easily available now in most stores. You can have a lower glycemic index rice, which is available in Asian stores, that has changed the ratio of amylose to amylopectin, so your blood sugars do not rise as much as regular rice. You could also add a little bit of finely diced cauliflower. Most people cannot tell that you've added that to rice. So these are some things you can do, because the more I am in this field, the more I realize that food and emotions are very closely linked. So it's very easy to have these prescribed dietary meal plans, but they will not work if you are not going to eat what is in those plans. So these are some things that has worked for me. And then I want us to think about processed grains versus whole grains, right? So the white rice, the pure white rice that we eat, really is so processed that it gives us no nutritional benefits. So we can look at whole grains, right? Something like steel cut oats or oat bran or quinoa, and we can mix that with rice. I'm not saying stop eating rice, but substitute, have half and half, or slowly, maybe you can say one meal a week I can do a whole grain rather than processed grain. And we want to remember that there are two main sources of carbohydrates, big groups. One is the grain group, to which all these belong: oats and bran and quinoa and red rice. And then you have legumes and lentils. So often people will say that legumes and lentils are a source of protein. Yes, they are, but mainly they're a source of complex carbohydrates. So they also help keep your blood sugars, within reasonable limits. And once again, remember, the carbohydrates to limit are those refined, highly processed carbohydrates like white rice and then all purpose flour, right? Of which a lot of our pancakes and other sort of breakfast foods are made. So we want to not have those highly processed carbohydrates. So I want us to quickly look at this picture of a whole grain. So I would like to point out that we should be aware of what we are eating, right? So read labels. If it says all-purpose flour or unbleached all-purpose flour, you want to know that that is not something that is diabetic friendly. So a whole grain has three parts. You have the bran, outer bran, then you have this huge, big starchy endosperm, which is basically starch and feeds this new germ that grows into a new plant. And this is what most of us end up eating, the starchy endosperm. But nowadays, luckily, this bran from grains is available separately. Wheat bran, oat bran available separately, right? So I will share a couple recipes of how to use those, because this bran is where the fiber lies, right? And fiber is something that mitigates the effects of high blood sugars, right? Always also look at portion sizes. If one slice of bread is telling you that it gives you 15 grams of carbohydrates, then remember, if you're taking insulin, then that 15 grams of carbohydrates has to be if you can get a slice of bread that is not so processed and has bran, then you will have much less of a glycemic impact than if you're eating something that's highly processed. So fiber, fiber, fiber. If there is one thing that you will take away from my talk today, I will say start paying attention to fiber. And of course, fats, the two F's, right? Fabulous fiber and fabulous fats, essential fats. So look at this. We need at least 30 grams of fiber in a day. Again, fiber helps mitigate the effects of high blood sugars. So, for example, a third of a cup of oat bran has 4 grams of fiber. It makes for a delicious breakfast food. Three-fourths of cup of cooked lentils is 11 grams of fiber. 1 tablespoon of chia seed, 5 grams, right? So what I do, for example, is I will soak 2 tablespoons of chia seeds separately. And then when I have a moment, I simply just drink that water with the chia seeds. The easiest thing to do, because if you have no time, then, instead of ignoring your fiber needs, you're at least drinking it in a very simple way. Then in Japanese food, there's natto, right? A very popular breakfast food in Japan, which we forget once we come to Ohio and we stop having our traditional foods. But natto is a great source of B vitamins, which a lot of diabetics who are on metformin, which is a common diabetic medication, get deficient in B vitamins. But natto is a great source of B vitamins, right? So that has 4.5 grams of fiber. So this is something to keep in mind. Flax seeds, again, 1 tablespoon gives 2 grams of fiber. So you can see that to make up 30 grams of fiber, you have to be conscious, you have to think about it and plan a little bit to make sure that you get fiber in your food. So how do we put it all together, right? So I want us to think about our plate, right? Every meal, whether it's breakfast, lunch, or dinner, I want us to think about this plate. This is the ADA's plate, and I have another example of it too. So 50% of your plate, right? One half of your plate, you should fill with vegetables, any kind of non-starchy vegetables, right? Green vegetables, bok choy, eggplant, cauliflower. I am sure in this wide spectrum of vegetables, there's some vegetables that you will find that you can like, right? So 50% of your plate should be vegetables. 25% of your plate should be a good quality lean protein, right? Again, we talked about those essential amino acids, good seafood, eggs, tofu. We want to put that in this quadrant. And then you want to have complex carbohydrates in your other quadrant. So this is something that visually, if you look at your plate, I want you to remember that every day. So for example, what are some good quality protein that you can do in this quadrant, right? For a lot of Asian Indians are vegetarian, so you can have tofu, you can have a good quality whey protein. There are lots of good sources of vegetarian protein these days. There is fermented pea protein available. There are these beyond products, beyond burger, beyond meat. So again, good source of pea protein. There's hemp protein. Then of course you have fish. So my strategy, and one that works really well, is before you start a meal, even for breakfast, if you have no time, just make sure when you go grocery shopping next time, buy a lot of mini cucumbers. Those are easy, right? So if you have no time to cook any vegetable or even chop any vegetable, you pick up a couple of mini cucumbers and have them for your 50%, right? Have cucumbers and tomatoes. Those are easy to do. And then you eat your protein, right? So you are full, you're satisfied, and then you come for your carbohydrates, because a lot of us tend to crave carbohydrates. So if you do this, these are simple tricks, right? So for carbohydrates too, notice that I don't have white rice here. I have other options. I have kidney beans, I have buckwheat, I have red rice, I have brown rice. So there are a lot of colorful, healthy, tasty options for complex carbohydrates that we can consider. So what are some quick fixes that we can have at home?
Susmita,
Yeah.
can I ask you, probably you might want to send some of this information on the chat so
Yes.
everybody can get the benefit.
Yes.
Since we have only 10 minutes for the question and answer,
Okay. Yeah.
I
I'll do.
don't want to interrupt you, but I just want to make sure that,
Sure.
we understand.
Sure.
Since there are people who might be interested in asking some questions also.
Okay.
So if you can send these things, we can also share it with our
Yes,
participants.
I'll do that. Okay.
Okay. All right. Go ahead and complete it. I just wanted to kind of.
Oh, no, it's fine. So
Okay.
I'll skip a little and I'll quickly say that among Asian, Indian, American subgroups, we can do simple tweaks like the Filipino dessert, bibinka, right? I love bibinka because it's available in parts of India too. But instead of using, sugar and white flour, you can use low glycemic index sweeteners like monk fruit or non-GMO erythritol or stevia. Believe me, you get the same taste because I make these amazing cookies with this non-GMO monk fruit, right? The Vietnamese pho is a great vehicle for having essential, amino acids, good quality protein, good quality carbohydrates. So eliminate the refined carbohydrates in the form of noodles. You can use buckwheat noodles. You can use whole wheat noodles in pho, right? Or when you do okonomiyaki of that the Japanese breakfast, again you can substitute quinoa flour for all-purpose flour, right? For Asian Indians, you can use wheat bran in your roti. You can take oat bran and make upma out of it. Believe me, it tastes better than rava upma. So these are some easy fixes that you can do, and I'm happy to answer questions later on, and I'll provide this PowerPoint.
Thank you, Susmita. I just wanted to make sure we need to talk about other things too.
Yes.
So I know Cora, are you there?
Yes, I am.
Okay, all right. Okay. Do you have to make last comments or anything, Susmita?
I'll answer questions.
Okay, all right. Thank you. Shruti? We were going to ask people to ask the questions. In the meantime, I also want to remind every participant to complete the survey that's sent, because it's really important for us to complete the survey because it's part of Ohio Commission on Minority requirement that everybody has to complete the survey. If you don't complete it, you might be receiving an email from us. Please respond to it. It's extremely important for us. Okay, thank you. Okay, go ahead, ask the questions.
Yeah, we can take questions either from the chat, or if someone wants to ask questions directly to the panelists, please raise your hand and we will unmute you. Okay, so what I will do, can you guys see my screen?
No.
Suchi, there is a question from an anonymous anonymous attendee, and he says, this question is kimchi part of the gut health probiotic? I guess that would be for Dr. Sadana.
Definitely. I love kimchi. My only tweak will be cut the sugar. Do not put so much sugar. You don't need it. You can make kimchi at home. I have a neighbor of Korean origin. She taught me how to make kimchi at home. Easy to do. Do not add the sugar. Just add, or at least cut it down to 1/3. But definitely gut health is where it all is. There's a lot of talk about gut microbiota, and majority of the serotonin of the body is made in the gut, so it makes you happy. Good food makes you happy.
I just saw a message from Dr. Lamb. Dr. Lamb, do you have to leave?
Oh, no, actually, I'm back. I'm good.
Oh, okay. All right.
He's back.
Thank you.
He's back.
Okay. What's the next
I have a
question?
question for Dr. Lamb.
Yeah.
Go ahead.
Yeah, so one of the question is, so AFib is one of the most common arrhythmias that causes hospitalization in the US. What is the prevalence of AFib for the Asian population?
So that, unfortunately, we don't have any specific data on AFib for the Asian American population. It is actually very common, and the things that predispose to AFib are actually a lot of the similar risk factors. So high blood pressure, tobacco use, those are all the same kinds of things. Other things that predispose to AFib are going to be things like sleep apnea. I don't know any prevalence data for sleep apnea specifically for the Asian American population, but this again points to the need for disaggregated data or even more specific data for the different ethnic subtypes because we just don't have that. But other things are also like thyroid disorders, a family history. Those are all the things that predispose to AFib.
Thank you.
It does look like we have a lot more questions though. Did we
There
have
is,
in the chat box?
there's a question from, let me see.
There is one by Ida. Whereas, how many grams of sugar in the labels is allowed for diabetics?
What a loaded question. Ada, let's speak after this talk and I can address your specific questions. But technically, I'm going to say that no grams of sugar are allowed for a diabetic, right? Because sugar is going to, exacerbate your situation. It's going to exacerbate your blood sugars. However, you can look for sugar substitutes like a good monk fruit sweetener with non-GMO erythritol, xylitol. These are safe substitutes had in smaller quantities, but you want to look at food labels and not pick products that have added sugar. So you should have absolutely no added sugar in the products that you pick. For example, um, for example, if you're looking for a good breakfast bread, right? One recommendation I have is called Ezekiel bread. 15 grams of carbohydrate per slice, but 4 grams of it is fiber, right? And there is no all purpose flour. Very satisfying, and it will not spike your blood sugars, but no added sugar is allowed. That's my one line answer.
Cora, the next question is actually from Karen. Is the diabetes self-management program still being promoted and taught?
The DSM, diabetes self-management and the chronic disease self-management is still being offered by Central Ohio Area Agency on Aging, COAAA. We are not, Manju and I used to be trainers for this, certified trainers, and so is Karen, but we are not offering it this time. We've offered it to the Asian community for several years, but my understanding, at least the latest that I've heard, is that COAAA continues to offer this CDSMP, chronic disease and diabetes self-management program through Department of Aging. And there are comments here. There's a question for Dr. Lamb from Eva. Idiosyncratic AFib is prevalent?
Yeah,
Greg is responding to that.
Yeah, I think that could have been a response to the question before with AFib for Asian populations. I was actually just looking it up and just doing a list search on PubMed, and for this again, there's not great data. It's a little outdated. In general, though, it looks as if AFib, the prevalence of AFib, is lower for Asian Americans compared to non-Hispanic whites. But it's still it's a little bit lower. But again, there's not demonstrated data, and that's mostly from the NACE study that came out, which was that multi-ethnic study.
These topics are just so important in such a short time. I tell you, I think it deserves an entire webinar for each of this topic. So we apologize for piling this up, but I think we got really a lot of information and new information and relevant information for us Asians that is culturally appropriate. Really, that's important. I hear the examples, and even statistics that really resonate for us as Asians, because we don't often hear that. I think we have to stop since it is that right, Manju?
Yes, it's 8 o'clock.
Okay, so we thank you so much for being here, and I know everyone is appreciative of this educational and informative webinar, according to Cecilia. We want to invite you, though, for tomorrow, Saturday's continuing webinar series, and it will be on mental health, coping strategies, and self-care management with an experiential power of the breath type of experience. So we will walk you through that as well. I hope you also sign up for the webinar tomorrow. We know that mental health issues is been a problem, and it's even more so during this pandemic. So we'll talk about that, coping strategies and self-care management. I just want to, I usually end up with reading the proclamation from the president, and I'll do that in an abbreviated way. I just want to highlight the fact that the highest elected official, the President of the United States, has really supported us and continued to support us during this time, okay, and has proclaimed May 2021 as an Asian American, Native Hawaiian, Pacific Islander Heritage Month. And I'm just going to read excerpts from it. So it starts with this May, during Asian American, Native Hawaiian, Pacific Islander Heritage Month, we recognize the history and achievements of Asian Americans, Native Hawaiians, and Pacific Islanders across our nation. In the midst of difficult year of pain and fear, we reflect on the tradition of leadership, resilience, and courage shown by these communities, and recommit to the struggle for AAN HPI equity. We celebrate and honor the invaluable contributions of these communities and their contributions to culture and arts, law, science, technology, sports, and public service, including the courageous AAN HPI who've served on the front lines of COVID-19 pandemic, like the healthcare professionals, the physicians and the nurses and all those healthcare providers, first responders, teachers, and other essential workers. During this year, our nation celebrates the achievements of Vice President Harris, the first person of South Asian descent to hold the office of the Vice President. She has blazed a trail and set an example for young people across the country to aspire to follow, including members of the AAN HPI communities and women in particular. My administration recognizes the heightened fear felt by many Asian American communities in the wake of increasing rates of anti-Asian harassment and violence during the COVID-19 pandemic, and increasingly observable layers of hate now directed toward women and leaders of Asian descent in particular. Our nation continues to grieve the senseless killings of 6 women of Asian descent in Atlanta and the unconscionable acts of violence victimizing our beloved Asian American seniors in cities across the country. Acts of anti-Asian bias are wrong, they're un-American, and they must stop. My administration will continue to stand shoulder to shoulder with these communities in condemning, denouncing, and preventing these acts of violence. We'll continue to look for opportunities to heal together and fight against the racism and xenophobia that still exist in this country. So Vice President Harris and I affirm that Asian Americans, Native Hawaiians, and Pacific Islanders make our nation strong. I urge my fellow Americans to join us this month in celebrating AANHPI history, people, and cultures. Now, therefore, I, Joseph R. Biden Jr., President of the United States of America, by virtue of the authority vested in me by the constitutions and the law of the United States, proclaim May 2021 as Asian American and Native Hawaiian Pacific Islander Heritage Month. I call upon the people of the United States to learn more about the history of Asian Americans, Native Hawaiians, and Pacific Islanders, and to observe this month with appropriate programs and activities. That's why we're celebrating this with this webinar series that we have started last week and will continue this week until Sunday. Again, I thank you on behalf of the Ohio Asian American Health Coalition, our Vice President Gregory Lamb, and our Secretary Eva is here. And I want to thank you for being here. I want to thank all those who've worked with us from the very beginning, Christina Geringer, who is the president of the Philippine Nurses Association, Yeshuan Lin, who is a graduate student, already have a master's degree in public health, was our intern, and Suchi Garg, who did all of this technical preparation, myself and Manju, all of us as a team work on this and able to offer it to you in celebration of Asian American Pacific Islander Heritage Month. I acknowledge the presence of members of our member organization. Suchi is from ACA. Mr. Don Hayashi, who's the newly elected president, I know he's here. We congratulate you, newly elected president of AAC. And Karen Jobu is here from AACS. Joseph Howe represents the Asian Festival Corporation Board. Cherry has a note. Let me read that.
Yeah, go ahead. There was a question, actually.
Oh, there was a question that you responded.
Yeah.
So thank you so much. And we invite
Thank you, Terry.
To the webinar tomorrow. And the last of the series on Sunday is not the same as what we have been offering, because it's an all-day mental health first aid training, and this would require pre-registration. I know there is very high interest in this, and our attendees, the number of attendees has already increased. So please plan to register. If you can't make it this time, we will continue to offer mental health first aid training to Asian communities in the next several months, acknowledging that mental health issue really needs to be addressed. I thank you, especially to Dr. Lam, Dr. Cohen, and Dr. Sadana. Wonderful presentation, so rich, so much information in such a short time. Thank you. We appreciate you all. Good night.
Good night, all.
Thank you.
Bye.
Yeah.
Take
Good
care.
night.
So I was able to acknowledge everyone, mind you.
You did, Cora. Good job.
Christina, Yashua, and Suchi.
Yeah.
Manju
Great.
has
Right, the
raised the
team.
hand.
What?
Manju, you
Yeah,
have
I
raised
had.
the hand.
Yeah, that was before when I needed to ask Cora whether I should interrupt. That's what it was. That's okay.
Okay. And
Interrupt
Karen
who?
has also raised the hand.
Yeah. Is she there?
No, she already left. She
Ah.
raised the hand. I
No,
think
there's
she
no one else.
Yeah, we
Oh,
have two more.
I believe you said, hey, Karen, let us know if you have any questions. And she didn't respond to that.
Yeah, because when I posted that, she almost like my question in the chat, and she almost left at the same time. So I
Okay.
assume that she haven't read this.
Okay. All right. Well, that's all right.
Oh, okay.
Anyway, it was a good session.
It was a lot. That was a lot of information.
8:30 would have been
That
better.
was a lot of information. Yes.
A lot of information. Yeah, remember initially it was going to be, but then we decided
8:30. Yeah.
decided to make it all the same.
Same.
Yes.
Yeah.
Which I think flows really well.
Yeah.
It really did flow really well. So I took attendance of the picture, but again, this survey has the student question, so we can capture who are the students for
Good.
this survey. But
Okay.
for the first 2 days, we can only just maybe check the ones that are student that
Or we can
came
send a
and,
note to
that,
all the attendees and send whether they are students. That's what I told Suji. Just send an email.
Yeah.
And ask
So
whether
what
they're
we
and I
need to
can
do.
already know by looking.
Yeah. So what I can do, like I will map the names with the registration list. And then I will identify the emails from there, because we don't have any emails or the contact details about the attendees when they attend. And there might be a possibility that the names which they are representing as an attendee and the names which they registered might be different. So we need to map that. We need to identify the emails ID from their registration list. And then we can send them the email and confirming whether they are students or not.
That will be good. Yeah.
Okay, I will help you out because I know the attendees actually, yeah, like couple 3-year students, but 11 actually from PNACOH. So
Yes,
a
thank
lot
you,
of,
Christina. Thank you, Christina, for marketing it, because we now last time we had several nurses, and this time I forgot to say this. This is also the nurses. No, last week was a nurses week.
I thought you said nurses. Yeah, you did say that.
No, last week was nurses week. Not because the nurses is only a week.
Okay.
Whereas AAPI is a month.
Okay.
So I can't. But also, Christina. Christina, is Ida Guerso a nurse?
Yes. Yes,
So,
she's
and
a retired
Irene is here, and Christina Garabant. So there were nurses here. There were nurses.
Yes,
also.
Faith is on the phone. She was actually, yes, Faith was
Faith.
on the phone. Lilette, John, Opaline. So at least 11 of them are nurses.
So, but they're not from PNACOH, right?
There are from PNACOH.
There are new members. I don't know. I don't think I know them. Who's Lily?
Yeah,
Anyway,
Opaline and John
wonderful.
are
Thank you, Christina. Thank you.
Thank you all.
Yes, I think we have increased.
You're welcome. Thank you.
Manju, I felt I have to mention Don Hayashi as a new president. That's why I decided to mention.
Hayashi, was he there? Was he there? Oh,
yes.
Okay. All right.
I had to mention him as a new president of
That's fine. No problem.
See, that's why I decided to mention all the other representatives of the organization.
Yeah, you have to. Yeah.
Who were there.
So how many of the one that are going to do the training, the mental health training? Anybody registered yet?
I have 16 registered.
You have 16. Okay, is Faith already in there and Lilette?
I don't see Faith.
Okay, so because she's interested of doing it, so I will make sure to register.
Yeah, so two more. Mind you, we stop at 20, huh?
Yeah. Faith, and who
We
is the
stop
other
at
one?
20, but
Christina.
we can schedule more in June because
June
we have
12th.
another one in June. If you miss this one, we have another one in June that we will
Okay.
Who is
do.
the other one? Faith, and who is the other one?
Lilith.
Lilith.
Oh, yeah, she's there.
She's there. Okay.
Lilith.
Yeah, I have her there. Yeah.
Okay, good.
Well,
All
Christina,
right,
did
so
we,
she's
did we have
also a
any?
student.
Do we have nurses from other states? PNA?
Bong was there last week. Did you see her?
Bong was there?
Yeah, Bong Dion was there.
Oh, okay.
I think Layla tried to, but she couldn't, and then she tried
Okay,
again.
okay.
Yeah, I think the link. She was having problem with the link.
Oh, okay. You know, so far it really has been very, very good.
Yeah.
I did not hear.
Yeah.
There were no questions for hepatitis B, unfortunately.
No, there was one. Yes,
One question.
asked, actually. Yasmin asked. Chatty
So
answered.
how was I heard Greg in the beginning, and then I heard also the nutritionist Sadana
Yeah.
at the end, and Chari I did not hear.
Yeah, it
Mind
was
you,
good.
mind you, does she have a PhD, the nutritionist?
Yeah, she has a PhD in Russian.
In what?
Russian language. Now
In Russia? Where?
Yeah.
Because her signature does
She's
not say
really good.
PhD.
I know. That's because she thinks Russian is not same as having a PhD. But I know she has a PhD in Russian.
No, but she has a PhD, but if she's acting as a nutritionist, it's not Russian.
No, that's not the same. No, she's doing her master's. I introduced her.
She's graduating in 2021.
Yeah.
This year.
Yeah. Medical dietetics at the Ohio State University. That's how we introduced her.
Her master's in.
Yeah.
Oh, okay. Yeah. But she wanted to be called doctor? Is that what it was?
No, she didn't have to. You didn't have to call her doctor. She didn't. That's okay.
Yeah, but I thought.
Yeah, that's okay.
But when I saw her signature, it says graduate 2021, just like Yashuin graduated 2021.
But she already graduated. I don't think Susmita is done with hers. Maybe
we added the title as an author for the Healthy Diabetic book. She's the author for one of the books. So that was the title which we introduced.
Okay. Yeah, medical dietetics. Yeah. Okay.
So do you have have I submitted my bio sketch, Suchi?
No, you sent us the presentation, but not the bio.
So who's introducing us?
Me. Tomorrow I am introducing you and Manju both. So I need the bio for Manju as well. And for Patch also, I haven't received the bio. She told that she will send it, but I will send her the reminder email.
I don't remember sending my bio sketch. And
no, you don't.
I was not asked either.
Oh, let me send you emails to all three of you.
You need it.
That's in W9. Yes. Just attach a W9 also at the same time.
A W9, you have to send us a form.
Yeah, that's why I'm saying, because they just revised it this year.
Okay. Okay. So I will send you, Suchi, my. I have a one-page bio sketch that you can just, select what needs to introduce.
Okay. All right. Okay. I was afraid we were going to run out of time today.
Yeah.
No, just too much. There was too much.
Yeah.
Yeah. But on Susmita's, really, people had a lot of questions.
Right. That should have been, maybe nutrition would have been another topic.
Yeah, you're right. We didn't think it was going to be that.
Did Cherry Cohen had PowerPoints also?
Yeah, she did.
She did. Okay.
Yeah. Okay. All right.
All right. Well, thank you.
Is there anything else we have to do for tomorrow?
Yeah, I have your presentations. So basically, you will share your presentations, but I have it as a backup plan.
Yeah.
Yeah. Do you have yours? Could I look at what you?
Yeah, I need to make some more changes to that because it does not have,
Okay,
certain things I need to update it. So
okay.
I sent her a
Suchi, do you have
copy.
patch? Do you have patch
No,
presentation?
No,
no.
I don't think she has anything from Patch.
Huh.
I don't think she will share the
Hmm.
presentation. It will be a live breathing exercise, I believe.
No, but she has a background information,
Okay.
explanation, the
Mhm.
benefits, the physiology, etc., and then she walks us through the breathing.
Mhm.
Just seem to be really busy now, you know?
Oh
Hmm?
yeah, oh yeah.
She doesn't have time. Okay.
She's
Well,
so overwhelmed, but she has. This is something that she has already put together.
yeah.
So
She does it
okay, all I
fine.
have to do is send you my bio sketch, and then tomorrow 6:15. I'll join at 6:15, right?
Why 6:15? 6 o'clock, Cora. You
But
made me join all the time at 6 o'clock now.
no, but because 6 o'clock, because we didn't know what really. Now we're good at it already,
I agree.
right, Suchi? I
Yes.
mean, in the beginning, we didn't even mention the members of our coalition because we were so into
Exactly. We
the
haven't done it any
logistics.
time. That's why
We just
today I
had
was
to
thinking that.
remember the
Yeah,
logistics. And
too
now,
many things.
okay, 6 o'clock is good if
All
you
right.
want 6 o'clock. I'll join
Yeah,
at
let's
six
do it.
o'clock. And then for Manju for Sunday, we're okay.
Yes,
All
Cora.
registration and everything,
I'm
all
okay,
okay.
but I still have to send an email to all those people today. I'm
Okay,
going to send it now because I have everybody registered already in the LMS system. So I
okay.
have to just send the emails to those people, which I will do.
All right. Now,
Oh,
is
but
it
they
going?
told me there is a new
I
link
know it's a
now.
new look.
Did you
Yes,
see
it
it?
is. I saw it. I
Okay.
don't like it. It's orange.
I don't. That's
I
what
don't
Tori
like it.
told me too.
What is
She
it?
doesn't like
Yeah,
What you don't like? Which
it's
one you don't like?
it's the website of the National Council on Behavioral
They
Health.
changed everything. But did you go through the
Oh.
PowerPoint? Have they changed anything in the PowerPoint, Cora?
No, I have I have the one where it's embedded, where the videos are embedded.
Okay.
I have that. But what's I going to say?
Is that the
So
one you access?
we go through Cornerstone, right? It's in the
Yeah,
calendar.
corner.
It's in the
Yeah,
it is that way, right?
it is there. Yeah. Uh-huh. Yeah.
And what I do
I
is
heard those.
I download the slides and then share screen. And then you
Uh-huh.
should
Yeah.
also be ready to download yours so that you'll be able to control it,
Yeah, definitely. Yeah,
right?
yeah. The last,
Same thing.
yeah, it sometimes doesn't work, so it's really hard. So that's good.
So,
Okay.
My hand is not up, is it?
yeah, I will put your hand
Okay.
down.
Okay. All right.
So what I
So
need
do
to
we?
do on Friday, on Sunday for the training. So we are not using this Zoom link. You have another link, the LMS link,
Yes.
which will be
Yes.
paid
Yes.
for the registrants.
Uh-huh. Yeah. Which I will
Yes.
be sending it out today, so all of you will have it.
Hmm.
So we'll see.
So we just need to
Suchi.
present. Hmm.
Oh, I'm sorry. Go ahead.
No, go ahead, Gora.
Suchi, this is the first time that we've used question and answer. That
Yeah,
right?
Yes.
that was the first
That's
time it popped.
Right.
yeah.
Now,
Because
Greg,
attendees they post their questions in the question and answers column, not in the chat.
right. But then the panelists can respond already, type the answer.
Yes.
Yeah.
And I know Greg was doing that. But when they when they type the answer, we don't have to read it out. People will just read it.
But
Is
you know,
that
the thing is, with Greg, I was kind of surprised nobody asked any cardiovascular questions.
oh yeah, Christina asked, and then Eva
I did.
asked.
Yeah.
Wait,
Okay.
did.
Okay. Sorry.
Eva
Sorry.
asked.
I missed
Eva
you.
asked.
Yeah. Yeah. That's true.
Eva also asked.
I
Now
thought there were going to be more. I thought there were going to be. He needed more time too. He needed way more
Yeah.
I
time.
want to understand how we're using this question and answer feature. So if you are Manju, you were supposed to be doing the question and answer moderating, right?
Yes,
I should not
yes,
be butting in. I should not be jumping in.
yeah.
And even
That's
Greg
true. That's
jumped in.
okay. That's good. We
No,
understand.
no,
That's,
no, that should not be. I think
I
if you
know
are
it was, yeah,
moderating, you should be in control of everything.
yeah,
You cannot,
yeah.
I cannot just comment on what's in the chat. I think I jump in when there is like a hesitation and a time.
Yeah,
If you're not responding, I should not, and nobody should. I apologize for that, because if Manju is moderating question and answer, everything should be under your control.
yeah,
You select who you want to, which one you want to read, who you want to call, and all that.
Yeah.
You know, I'm still not clear on this question and answer, Suchi. So
do we record all the question and answers too, Shruti? All the everything in the chat box?
We can get it from the recording. I believe Zoom might have the recorded chats and the question and answers. So
Okay.
we will have the list.
I think whoever is moderating